Good morning, and thank you for joining the Ask the Experts COVID-19 virtual town hall, where we hear from about the current issues at Chapman and our community from a wide range of disciplines. My name is Tom Pihota. I'm the Vice President for Research here at Chapman, and I'll be moderating this town hall. It's certainly a timely discussion today, given the rise in numbers in the coronavirus, the impacts on different populations, and the recent announcements that have been made on the vaccines and treatments. So we're really really glad that you're able to join us. And I think you're going to find the experts that we have gathered today with some good information to present. I'll be introducing them in a minute here, but I do want to say Chapman continues to monitor the local and state conditions for our faculty, staff, and students. And as you've read in President Struppa's messages, he will continue to update the campus on a regular basis in terms of what the status is for the campus. I will say that's not really the focus of what the experts will be talking about today. They'll be talking about different things from their different disciplines today. So we appreciate the questions that you'll have for them on this bigger issue that impacts both our Chapman community and also the broader community. I'll be introducing each one of them. They come from a broad range of disciplines, giving in the business community, science, community health, pharmacy. We really want you to engage and ask lots of questions also. On the right-hand side, you should be able to ask questions of the experts, and they'll either answer those directly, or we'll have plenty of time for asking those questions after they make some brief remarks. You can even start asking some of those questions now. So with that, let's go ahead and get started, and I'll make my first introduction of the first expert. First expert is someone who's been on these panels various times. He's Dr. Stephen Gerstad. He's a presidential fellow in the Economic Science Institute in the Argyris School of Business and Economics, and we're thrilled to have him back to give us some updates on the numbers out there. So with that, I'll turn it over to Dr. Gerstad.
Thank you, Tom. So I'm primarily here, I think, to kind of set up some context for the detailed discussions about vaccines and symptoms and other or the effects of COVID that the other participants will be given. I have basically 2 points to make. One is that the cases are rising rapidly, and that they're rising all over the country at rather alarming rates, and that the second point that I'm going to make is that there's been a lot of discussion about declining mortality from COVID, and I'm going to point to evidence that indicates that that's not the case. That about 90% of the apparent reduction in mortality is coming from a shift in the ages of the people who are contracting COVID. The age has fallen considerably, and that seems to be the principal element in the apparent declining mortality. So this slide shows the number of cases in the U.S. going back from February to the present. We see the
If your slides are advancing.
My slides aren't advancing. Okay.
Hey, Stephen, sorry. Would you mind stopping the share and resharing? It errored out on my end for some reason.
Okay, I can do that.
Yeah,
I can do that. I hope kind of quickly.
Sorry about that, everyone.
Is it back?
All right, one more time. It's back now. Yep.
Is it advancing?
Okay.
Thank you. Sorry about that.
So these are the cases in the United States. We see the first rise back in March, and then the peak in the very early part of April. We saw the very slow decline over the course of about 2.5 months, then a fairly rapid increase, once again a decline, and now a rapid increase. If you recall back in the first wave, it was the large number of cases and large number of deaths were primarily in the urban Northeast, and particularly in the metropolitan New York area and the vicinity around that. The second wave was a bit more widespread. It was Florida, Arizona, Texas, California, and a few other places. The third wave, I'm going to describe to you or show you quickly how widespread it is geographically and how rapidly cases are rising. So places that avoided really large, both large effects from the first and second wave, like Minnesota, Ohio, are rapidly increasing. Places that saw rapid rises in the first wave, like in the second wave, like California and Texas, are also seeing cases rise quite rapidly. And then, you know, in the Midwest, especially the upper Midwest, where it's getting cold now, cases are rising. They're showing in Wisconsin, Indiana, Iowa, Illinois, and there's kind of no indication that this rise is going to stop in, say, the next couple of weeks, which could push us into a realm where we're getting 200,000, maybe even 250,000 cases a day. What I want to show you next is just how severe the number of cases is in some of these places. North Dakota has the highest number of cases per day per capita. So they've got about 1,246 cases per week per 100,000 residents. So basically, you know, in terms of being diagnosed with COVID, it's about 1.25% of the population every week. In New York, when they had their large peak back in March, the number of cases per capita per week was 362. So North Dakota is maybe 3.4 times as the number of cases is about 3.4 times as prevalent as it was in New York. I think that just gives North Dakota is a small state, so the number of cases don't look really large, but it's severe, and it's severe not just in New York or in North Dakota. It's in both the Dakotas, Montana, Wyoming, Wisconsin, Minnesota, Illinois, Indiana. It's just really spreading out throughout the upper Midwest and the Mountain West. The next thing that I want to show you is some evidence from California that I don't think this is indicative that the mortality is decreasing. So I'm going to just focus on one row to just get the kind of the concept here. The percentage of all cases among people who are between 18 and 34 is about a little over a third, and the death rate is about 0.1%. That was from the inception of the pandemic until August 28th. From August 29th to October 31st or 23rd, it's still about the same, 35%. And about 0.1% mortality. If you look at the 60 to 64 age group, the percentage of cases is still about the same, but the mortality has actually increased. And if you look at other age groups, 65 to 69, mortality has increased from about 5.3% of cases to 7.6%. 70 to 74, it's increased from 8.6% to 10.4%. So mortality is remaining a significant problem. In New York, it's slightly different, but the composition of cases, say among people 75 plus, they were 11.7% of the cases from March 1st to May 16th. That's dropped now, but the mortality among those people has actually risen. The mortality in 65 to 74 has fallen slightly, but there's a big change in composition of the cases. In the most recent almost 5.5 months, the number of people in the 18 to 44 age group and the 0 to 17 age group has gone to about 57%, up from about 39%. So there's a big change toward younger people, and that's making an apparent decline in mortality from 8.3% to 5%. But within the age groups, it remains significant mortality. And the problem is for people who are 60 plus, it doesn't matter that more younger people are getting it and recovering. What matters is what's happening within your own age group. And there's not a lot of improvement there. Another factor that is probably going on here is that, you see a big difference between mortality in New York and in California. There are different strains of coronavirus. So there was apparently a mutation that took place when it went to Italy, and that was a more lethal strain. That strain came here to California. That went to New York. The strain from China came to California, and that strain has been less lethal. So I think those are the primary points that I wanted to make. First, that cases are rising. They're rising all over the country, but particularly in the northern tier of states, and that the belief that mortality has decreased substantially is perhaps a mistaken one. It's most likely primarily due to a change in the composition of the age groups that are contracting coronavirus.
Great. All right. Well, thank you very much, Stephen, for those interesting figures and gives us a good context. Our next speaker is also a returner to Ask the Experts, Dr. Jason Douglas. He's an assistant professor of public health in the Department of Health Sciences in the Crean College of Health and Behavioral Sciences. And with that, I will turn it over to Dr. Douglas for his short presentation.
Thank you, and good morning, everybody. Thanks for having me today. Just want to check in. Can everybody see my slides?
Yep.
Perfect. Thank you. Okay, well, thanks for having me here today. So I'm going to be sharing some of my ongoing research looking at the impact of COVID-19, particularly in disenfranchised communities, wherein I'm looking at social and environmental determinants of COVID-19 mortality. So before I move on, I do want to quickly recognize my faculty and student colleagues who have been instrumental in moving this research forward. So many thanks to them. So the objectives for my talk today are twofold. First, I want to go back to the initial town hall that I presented at in April and share some of my ongoing findings looking at COVID-19 treatment resource disparities in New York City. And then second, I want to pick up on some of my ongoing examinations looking at social and environmental determinants of COVID-19 mortality in two major US cities. It's going to be New York and Los Angeles. So to start off with, what we know so far. Throughout the course of this pandemic, look, Black and Latinx communities have really endured a disproportionate burden of COVID-19 incidents and mortality. We're seeing some of the heaviest rates in our Black and Latinx communities. Second, what we're also seeing is that Black and Latinx communities don't have equal access to treatment resources. We're not seeing this same kind of resources within our communities for treating COVID-19, and this is not surprising since we're seeing this in terms of healthcare access broadly speaking. For example, in some of my recent research published in Preventive Medicine, wherein I looked at treatment resource disparities in New York City, for example, during the peak of COVID-19 in New York City in April, when I looked at hospital resources such as hospital beds, when I looked at the disparities between majority Black and Hispanic compared to majority white communities, the disparities were astounding. For example, in majority Black and Hispanic communities, at the peak, there were roughly 10 beds per 1,000 persons of the population available to these communities. Whereas, again, peak pandemic, in majority white communities, there were almost 76 beds per 1,000 persons of the population. So building on this research, what I wanted to do was extend the research program to look at what is really driving, perhaps, mortality rates amongst minority groups in the cities of New York and Los Angeles. So looking at aggregated COVID-19 mortality data as of September 15th, in the New York City context, what I found, again, comparing majority white to majority Black and Hispanic communities, the death rate per 100,000 persons of the population in New York City's predominantly white communities was 158.5 compared to 262.5 in majority Black and Hispanic communities, a glaring disparity. When looking at Los Angeles City, again, comparing majority white communities with majority Black and Hispanic communities, what I found was while the death rate was lower, there's still quite a disparity. Looking at 45.7 deaths per 100,000 persons in majority white communities, compared to over 66 deaths per 100,000 persons in majority Black and Hispanic communities. So what I wanted to do was look at some of the social and environmental drivers of mortality rates in these cities. So I decided to test a model. First, looking at what we knew about the mortality context in New York City, I developed a model wherein we would look at race and ethnicity, population density, sex, age, income, percentage of renters, as well as citizenship in terms of associations with COVID-19 mortality. What I found is that in New York, as a percent of Black and Hispanic residents in a community increased, mortality increased, COVID-19 mortality increased. As population density decreased, mortality increased. And this actually made sense because the most densely populated areas of New York City are in Manhattan, which tends to be predominantly affluent and white. Also, as age of the community, percent of residents over age 55 in the community increased, COVID-19 mortality increased. As income in New York City decreased, COVID-19 mortality increased. And interestingly, when I plugged in the percent of residents that do not have citizenship status, in the third step of this model, I found that as percent of residents that do not have citizenship status increased, COVID-19 mortality increased. Now, I wanted to test my hypothesis that citizenship matters in terms of mortality. So looking at this model in the Los Angeles context, when I plugged in percent Black and Hispanic, in the initial step of the model, percentage of Black and Hispanic residents within a community, as it increased, predicted COVID-19 mortality increases, similar to New York. But when I plugged in additional social and environmental variables, it actually dropped out. And the remaining variables that were significant in predicting mortality increases in Los Angeles were as age increases, mortality increases. And then there was a very strong effect of citizenship. Whereas as a percent of residents in Los Angeles City communities increases, COVID-19 mortality increases. So the takeaways from this, look, Black and Hispanic communities have clearly borne a disproportionate burden of COVID-19 incidence and death. This is clear. But what we're not seeing reported by our public health departments, and this is critical, is that citizenship status may be a major driver in that non-citizens may not have equal access to treatment resources, to the resources that many of us have for avoiding disease. Therefore, I argue that we need to ensure that we have health protective resources allocated to Black and Hispanic communities, particularly those with high proportions of residents with non-citizenship status, which we know overlap significantly in our Black and Hispanic communities, both in New York and Los Angeles. So with that, I'll finish off by saying, please do stay safe and healthy. Thank you very much.
All right. Thank you, Dr. Douglas, for those interesting research results. And I think that fits in nicely with kind of the next two presenters who are going to talk some about treatment strategies and vaccines. So I want to move on to our next presenters, who are both returners. Dr. Jerica Lamb is our next presenter. She's an infectious disease pharmacist and associate professor here at Chapman School of Pharmacy. And she's also a member of the Patient Safety Movement that you'll hear some about, the Patient Safety Movement Foundation, their COVID-19 task force, and their education committee. So with that, I will turn it over to Dr. Lamb. Are you muted?
Yes.
Oh,
Hi, can everyone hear me? Okay, great. Well, thank you very much for the kind introductions, Tom. Good morning, everyone. And I'm going to speak or share with you data today, just brief data about the therapeutics for COVID-19 and what we now know. As we know, there's just a barrage of information on a daily basis. So before I talk about the therapeutics, I want for us all to take a closer look at COVID-19 infection and disease and the information that we've gathered over the last approximately 9 months of understanding this virus. And this is a snapshot from Dr. Gandhi's publication. Dr. Gandhi, Raj Gandhi, is from the Harvard Medical School, and basically, he did a phenomenal job in detailing the 5 stages of infection, ranging from asymptomatic to critical illness. And as we can see here in this table, that basically testing is primarily required for those who are succumb to mild illness with some symptoms, and of course, diagnostic testing with RT-PCR is recommended throughout the whole course of illness. Isolation is recommended for those who are suspected of being exposed to someone who has the infection. And further down here is that we understand that viral replication now is highest in the initial days and hours of the infection. And of course, it still progresses throughout the course of illness. And then inflammation, as what we all know, cytokine storm, actually occurs later on. And that is where it revs up the host immune system to cause more severity and damage to the organ systems in the host body. What we also have here is that antiviral therapy, and I'll talk more about that, but we basically, even though we know a little bit more about this virus, we don't have very effective therapeutics against this virus still. And so we're basically using antiviral therapy as well as refurbishing other potential therapeutic agents for their antiviral properties. And then the discussion briefly upon antibody therapy as well as corticosteroids. Before I talk about the therapeutic agents that are being considered for COVID-19 infection, I want for us to remember the various complications that are associated with COVID-19. And these are the extrapulmonary manifestations of COVID-19. And I just wanted to highlight the cardiac issues that still linger in patients who have survived COVID-19. They're considered the long haulers, as well as the neurological complications that come with that, and also those people who have survived have experienced and have reported having some form of clotting issues, such as deep vein thrombosis and pulmonary embolism. So these patients, even though they have recovered and are discharged from the hospital, may need to be anticoagulated still to prevent the clotting issues that stem from this infection. And other long-term implications that we have learned so far from this infection is that the chronic symptoms extend beyond 12 weeks after infection. The symptoms can include shortness of breath, fatigue, having joint and chest pain. Other manifestations include neurological effects. Patients have complained of having ongoing headaches, having vertigo or dizziness, and having this sensation of having brain fog. So not really being alert cognitively and not being able to function cognitively. So these are things that are basically surfacing among clinicians, and we have yet a far ways to understand the neurological impact as well. And many of us have known for those treating patients who have survived from COVID, there is a psychological toll and impact, emotional health and well-being that encompasses patients experiencing anxiety from this illness, as well as depression and also PTSD from being hospitalized. So let's talk about the therapeutics that we have so far, and there are basically 3 therapeutic classes: the antiviral class, the immunomodulators, and the antibodies. And what I want to illustrate here is that we know that there's a plethora of clinical trials going on right now, but in terms of the efficacy of many of these therapeutic agents, there's not much, unfortunately. We know that remdesivir was the first antiviral agent that has received the emergency use authorization from the FDA, and more recently, in October, it has received FDA approval. And this was based on the Solidarity trial. However, what we found out is that from this Solidarity trial that was primarily conducted by the WHO and the NIAID institution, is that the mortality has not improved much compared to placebo. What that means is that remdesivir actually has really not much of benefit in reducing impact of death. It has shown in other trials previously, the ACT-1 trial, that has reduced the length of stay in the hospital, but the primary outcome for all these trials that we see here have looked at mortality improvement, and remdesivir has really modest to minimal improvement in mortality. Still, it is better than nothing when a patient is severely or critically ill. As we move over to the immunomodulators class here, we have the corticosteroids, primarily dexamethasone, and the corticosteroids actually do play a significant role in patients who are severely and critically ill, because at that time, as I've shared with you in the previous slide, the cytokine storm is actually revving up and using the various interleukins and the various pro-inflammatory proteins to attack the organ systems in the host body. So the immunomodulators, especially the corticosteroids, actually are very effective in dampening that cytokine storm and to prevent further damage to the various organs, such as the lungs, the heart, and the kidneys. And then the other class that we have talked extensively about, and you've probably heard about in the news, are the antibodies class. So we've talked about the convalescent plasma or convalescent serum and the monoclonal antibodies. And I've highlighted here is that convalescent plasma, and the only monoclonal antibody right now that we have approved for emergency use authorization is bamlanivimab. And basically, they work in similar instances, but bamlanivimab actually is a little bit different. It is a monoclonal antibody that directly targets the spike protein of the virus, and so preventing it from actually attacking or attaching to the ACE2 receptor of the epithelial lung cells. So the takeaway from this slide is that there is a flurry of trials as well as data that are constantly being analyzed and evaluated to see if there is any efficacy in reducing symptoms as well as reducing mortality. But as we know right now, we still don't have that holy grail weapon or holy grail therapeutic to actually reduce the impact of this disease. And lastly, I want to share with everyone here that as what Tom has nicely alluded to earlier, is that I've been actively involved with the Patient Safety Movement COVID-19 Task Force, and we meet on a bi-weekly basis to discuss about the various up-to-date information about COVID-19, as well as inviting various expert speakers and scientists to come onto our webinars to discuss about, for example, brain fog from survivors of COVID-19, as well as the various therapeutics. And so this is a website that anyone can register for free and go on. And as you can see here, there are other helpful resources on this Patient Safety Movement website, but I just want to bring everyone's attention to COVID-19, and the helpful resources are made available for the general public, clinicians, hospitalists, as well as patients who are hospitalized, and perhaps their caregivers want more information about what is really going on with this infection and what are the treatment options that are available for them. So thank you very much for your time.
All right, thank you very much, Dr. Lam. And lastly, I want to introduce Dr. Jeff Goad. He's a professor and chair in the Department of Pharmacy Practice at the School of Pharmacy, and he's a member of our state COVID-19 vaccine drafting guidelines work group. So I think you're going to find the work that he's presenting to be very interesting and timely. So with that, I will turn it over to Dr. Goad.
Great, thanks, Don. And thanks to all our presenters. I think they set this up really well, which is we have a situation that's not getting better. We have lots of disparities in who's getting sick, how sick they're getting. And we have, unfortunately, not a great lineup of drugs to treat the disease. So vaccines to the rescue. Let's talk a little bit about vaccines. Okay, so just to orient everyone in what we're all dealing with here, is in all the vaccines, whether we're talking about mRNA vaccines or DNA or protein-based or recombinant, doesn't really matter what you're talking about. What we're trying to do is target the main epitope, which is that protein on the outside of the virus that your immune system sees when it encounters that virus. And so for our vaccines, we're all working on what's called a prefusion spike protein. So this is the little thing that sticks out that gives it the corona look when you put a whole bunch of them together.
Interrupt you real quick. Did you want to share your screen? Okay. No.
Oops. Let me try it again.
It's all right. I wanted to make sure everyone was seeing it. There it goes. It's coming up.
Let's see. Can everyone see it?
We're seeing your notes slide. Try switching.
Oh boy. Let's see. How did that happen? That worked perfectly before. We'll try sharing one more time here. Here we go. Let's try this. Are we seeing it?
We're seeing it. Then put it in presentation mode now. There you go. Perfect.
Aha. Okay. Got it. Me and Teams don't seem to go very well together, but Zoom works fine for me for some reason. Anyway, so I was only on this slide. So now you can all see what I was talking about, which is the spike protein on the outside of the coronavirus, which is the main way that it gains entry into your cells. So you see this little diagram down here as it gets to the ACE2 receptors on your cells is how it actually gets in there. What you're also seeing floating around there, and we're going to start talking a bit about this, is your antibodies. So antibodies, the way they work is they bind with the antigen in your bloodstream before they get into a cell, right? But that's not all of the whole. It also has to be anti-neutralizing. So in some of our vaccines that we're seeing, some of them bind but don't neutralize. And the ones that bind and neutralize are the ones that are in our phase 3 trials and moving forward. Okay, so these are the ones that we're most focused on. And I'm really going to focus in on the top two, which are the two mRNA vaccines, Moderna and Pfizer's vaccine. There are a couple that I put phase 2, 3 because some of the trials are actually being combined. So in other words, we don't have as clear delineation between phase 2 and phase 3 in some of our coronavaccine virus trials, such as Janssen's and the adenovirus vector. So I'm not going to talk about those, but just real briefly, the adenovirus type vaccines are you take a different virus, in this case an adenovirus, you knock out some of its genes and you insert the ones that make the spike protein in there, and then insert that into the body. Those will become important later next year when you see these vaccines being released onto the market. And then the ones down below, for example, Novavax, which is recombinant protein plus adjuvant, that's a platform we've been using before, so people might be more familiar with that one. And that's actually a one-dose vaccine that's coming down the market, where all these up here are 2-dose. So there's going to be a lot of variety of vaccines. But what do we have coming first? This is our mRNA vaccine. So real briefly, it's a totally different concept. Sometimes it's hard for people to get their heads around, which is we're not actually injecting the vaccine into you. What we're injecting are the instructions to how to make a vaccine, right? So what we're doing is injecting mRNA, right? You can see this little pictorial here that goes into your body, into your muscles. This is intramuscular. So we'll inject it in your arm, in your muscle cells. It's actually going to start to go inside the cell. It's going to begin to make, so it'll just avoid the DNA side, which takes longer. It's just going to give instructions to tell your cell how to make the spike protein, which is then going to expose itself on the outside of your cell, allowing your immune response to now see, oh, this looks like coronavirus. So your own cells are going to make the vaccine. We don't have any other vaccine platform that we've ever had licensed that does this. Pretty novel, pretty innovative. And this is what Pfizer and Moderna vaccine are doing. Now, it's also a good time to do this town hall because guess what? Last night, Moderna announced their findings. Now, I have to caution, these are interim endpoints, meaning that they unblinded, looked at the number of cases, and they had to have about 90, 95 cases in the interim subgroup analysis to be able to unblind and look and see and calculate vaccine efficacy, which is what they did. So for Pfizer, they announced about 90%, Moderna about 94%. I wouldn't get hung up on the exact numbers. These are midpoint estimates. The trend will very likely stay solid, that it'll be over 90%. But you might see these vaccines actually get closer together in terms of percent efficacy. The other important point to know about this, because lots of people have questions about, well, what are they actually preventing? What are they actually looking at in the study? This little chart here, I think, helps to understand what the endpoints actually were and why we could do this so quickly. So for SARS-CoV infection, you have symptomatic or asymptomatic. And I think Dr. Lamb showed you very well how those two play out and where the viral loads are and what the symptoms look like. The study is actually powered to look at only symptomatic, right? So that is part of the monitoring process. It wasn't waiting till you got severe disease or even to see if your progression of symptoms went on just to non-severe, right? It was simply looking at symptomatic disease. So we don't have a good idea if it prevents severe disease, but we do know it prevents symptomatic disease. We also don't know what it does for asymptomatic transmission, which is 40 to 50% of transmission. Again, was not powered to look at that, right? So we had to wait till you were symptomatic before they called it a case and they assigned it either to placebo or to the vaccine itself. So the asymptomatic side of it, and whether this is going to halt transmission on a population basis, we'll have to wait further when we start to look at more post-licensure or post-EUA, emergency use authorization of the vaccine to learn about its interruption of asymptomatic transmission. So on to distribution. So vaccines are coming, right? We have heard, but it's my ear to your ear is we're all listening to the same sources, right? Which is something announces at midnight and we find out when things are happening. But we anticipate that we'll have vaccine somewhere in December, right? That's what in the state of California, what we're planning for. California has one extra step, just to give you a real quick what's going to happen, is the company is going to submit their data to FDA. FDA is very likely going to go through EUA. They're going to send that to VRBPAC. VRBPAC is the FDA advisory committee is quickly going to turn that around, send it back to FDA. They'll grant an EUA. At the same time, CDC, through their committee called ACIP, it is acronym overload, I apologize. CDC then will get it and they'll make a recommendation on it. And then it'll go to California, who has their own science board, who's going to do a CDC type review and give the thumbs up on it. All along the way, what's coming in there is something called data from the Data Safety Monitoring Board. Something totally unique that they did for all these vaccines and study. They have one DSMB, one Data Safety Monitoring Board. which is awesome because all of the adverse events are flowing through this one entity. They'll know in every trial in the United States and be able to aggregate it together. So we'll have a really good picture of the safety and efficacy of these vaccines when they come out. Now, you're wondering, am I going to get the vaccine? Well, it depends. So if you're in phase 1A, right, this is the high risk group. So these are hospital workers, for example, or people in pharmacy. So pharmacists, for example, are in the high risk group. Dentists are in the high risk group. So there's a group of people there, and we calculated that somewhere between 1.2 to 2 million people in California fall into this group. We're expecting about 1 to 2 million doses of the vaccine. So it's going to be cutting it close, but that assumes that 100% get the vaccine. Right? Now, where do you come in? You'll probably, if you're a professor or if you have a different job at the university, you're going to come in probably in phase 2, definitely in phase 3, and then everyone by phase 4. And this is what it'll actually look at in terms of timing. So phase 1, limited distribution, just 2 vaccines we're looking at. Pfizer will get us vaccine first, and then followed by the Moderna vaccine. Both of those are mRNA vaccine with very similar efficacy. We'll have limited supplies and we'll get to our high-risk populations. And these are not high risk because of their own disease states, but high risk to protect them in case they got sick and they're not there to take care of you. That's how we determine who's in that first high-risk group. Part of the other phase 1 high-risk group are nursing home, skilled nursing, long-term care. Those people who take care of those residents are critical care providers, because we know, as Stephen showed us, still our highest risk group for mortality is our older individuals, and especially those with comorbid conditions. Now, as we get into phase 2, the U.S. government purchased 100 million doses of Pfizer's vaccine. It's a 2-dose, which means that we took care of 50 million people. There's still a lot more people in the United States. The good news is these are highly scalable vaccines, meaning they can make a ton of it in a very short amount of time versus, say, our old live attenuated vaccines, which could take a very long time to make enough to help a population. So we've got a lot of good things on our side that I think we can get vaccine for the public. And we're probably looking at to get it to the masses in the public in late spring, summer, somewhere around there. But we think by the end of the year, we'll definitely be into phase 3, where we've got just about everyone coming through. So quick run through where we are in the vaccine, and I'll turn it over back to you, Tom, for questions.
All right, great. And thank you all. Those are really great presentations, and I think sets it up nicely for some good Q&A, which we're already getting people posting questions in there, which is really great. And I may just jump right into some of their great questions. I think what's on everyone's mind, and I think what Jeff presented at the end there is kind of what's on a lot of people's mind, is kind of what's next, and kind of, I think I maybe want to start out with kind of the issue of confidence in vaccines that are being developed, and the extreme, the quickness of these being developed. And I think a lot of people are wondering is, how confident should they be in the process? Jeff, you nicely outlined the process of that approval and the announcements that we just heard today. How confident should they be in that process? Because it's an accelerated process in the development of a vaccine. And secondly, what will be done? What do you think will be done to monitor the potential for long-term side effects, which you can't really do when you have an accelerated development of a vaccine also? So I'll leave it for actually the whole group to potentially jump in and answer any parts of that question. So anyone want to start?
Sure, I can jump in there. I'll start. Okay. So you're dead on with the vaccine confidence issue. That's something that on CDC calls, FDA, state-based public health, everyone's very concerned about making sure the message is clear to the public, right? And people are kind of confused because sometimes when politics gets involved with science, things get all mucked up, right? But what they did in these vaccine trials is very unique, is that they threw a whole bunch of money at it. If you can pump a lot of money into the system, except for the Pfizer vaccine, who mostly funded this on their own, the other vaccines used NIH and other sources of funding. If you can put a lot of vaccine funding into this, you can run a lot of trials simultaneously. You can power them by having larger numbers in a smaller amount of time. You can enroll very quickly, right? Where sometimes it's very expensive to enroll people in these phase 3 trials. That's why they take longer. So they were not cutting out any steps. They did a whole bunch of steps in parallel. To your question about the safety side of it, that's where all those committees from VRBPAC, ACIP, California's, and actually they're part of a Western front to look at safety for the vaccine as well as efficacy. That's where we have to be transparent. And we've talked about this in on our both state-based as well. In the state of California, we have another committee called the Community Engagement Committee. So there's 3. I'm the one that talks about how you get the vaccine. There's the Science Committee, and then there's the Civic Engagement. So they're talking about how do you make consumers feel comfortable in the information that's coming out, that they can trust it and they can rely on their healthcare providers when they tell them, right? And it's not just the consumers. We also have surveys that show that healthcare providers may not get the vaccine in droves. We're planning, assuming they're going to use every dose of it, but we know that some, for example, nursing surveys suggest that nurses may not get it, as may not stand in line right away to get it right away, like say their physician colleagues or pharmacists or other groups in that area. So we do have some work to do on communication.
Great. Anyone want to add anything? Jason, you want to add anything, given kind of this is a communication issue for certain communities and instilling a certain level of confidence?
Well, sure. First of all, great presentation, Dr. Goad. And I'm actually really interested to sort of extend that conversation a little bit more. I appreciate the concern about communication issues, but I'm particularly concerned about who has access to these treatment resources, right? Obviously, that's my lens. So I guess I'm sort of posing a question. What sort of considerations have been discussed about prioritizing disenfranchised, underrepresented groups where we're seeing disproportionate rates of COVID-19 mortality, Black, Hispanic, and now in my most recent findings, folks that do not have citizenship status, where we know, right, this is a major challenge in terms of accessing healthcare resources. So I would love to hear more in terms of what's going on there.
So I think that's a great point.
Maybe
sorry, Tom. Yeah.
Maybe to start, maybe Jerica, you could talk some on the therapeutic side, because there's really kind of, my understanding, there's kind of the issue of access on the therapeutic side, and then access eventually on kind of access to the vaccines also. Jerica, you want to start maybe?
Yes. Hi. I mean, that's definitely a valid and relevant question, Jason. With regards to the therapeutics, as I understand, the allocation of remdesivir now, since it is FDA approved, before, let's take 2 steps back. Before it was approved, it was issued EUA status, and so prescribers were able to prescribe it and receive the medication from Gilead, the manufacturing company. Of course, as I read the papers, there wasn't a deeper dive into the health disparities, to be honest. And so we don't have much information in terms of whether the minority or the underserved populations received less supply of remdesivir versus more versus maybe the Caucasian and affluent communities. We don't have that information, because within the therapeutics realm, we were focused on efficacy as well as reduction of mortality as our primary endpoint. And so it is a valid question, and I don't want to make a presumption or assumption statement saying that the underserved communities did not receive it. I believe they did. In terms of the actual numbers, I don't have that information. But now, since remdesivir has received the FDA approval, now it is up to the various warehouses that, the various buyers that can afford buying the various supplies to their hospitals. And again, please keep in mind that remdesivir is only indicated for patients who are severely to critically ill. So it is not used in patients with mild to moderate symptoms, because the science and the evidence of clinical efficacy is not there.
Great. Jeff, you want to speak some on access for different communities with how they're looking at that for vaccines?
Yeah, no, I think Jason is dead on, which is one of the things that it was instilled to us from day one when I joined this work group, is that equitable access is a driving factor in how we determine prioritizations. So on one of my slides, like number 6 or so back there, there's something called the CDC Social Vulnerability Index, and Jason's probably a lot more familiar with this than I am. There are about 15, is that right? 15 different, yeah, okay, got it right. So there are about 15 different indices that we were given. So we get all the GIS mapping, for example, in LA County and other places throughout the state, where these pockets, because they do census tract layering, they put it in there to show us where these pockets of vulnerability is. And we get down to the micro planning level, because our job is to tell LA County or Nevada County, or these little tiny to big counties, what are some guidelines they should put into place to prioritize vaccine administration when there's limited supply, given these pockets of resource poor areas. For example, where we are, a recent discussion I'll just tell you we had, Harbor UCLA sits in Torrance, right? Torrance is not an underserved community. Harbor UCLA serves an underserved community. So some of our, our social vulnerability index would lead you, might possibly down the wrong road. So we also need to combine that with what populations they actually see. And that's the hospital census type data and the demography of who actually goes into, for example, Harbor UCLA.
Great. I'm going to move to Stephen and give Stephen a question. So Stephen, you're our numbers guy, and you showed a lot of the recent numbers and the concerns we should all have with the increase in cases, and how that spiked lately. What does it look like? And obviously Jeff laid out nicely the timeline for vaccines coming online. So this is certainly going to be staged and going to take a little while. What does it look like? What do you, as you look out over the next few months here, what should we be looking at in terms of, and you look in your crystal ball in terms of cases and the potential of vaccines also coming online, because it's going to take a little while there.
Yeah, I think there are going to be some challenges with that. One challenge is that both of these mRNA vaccines require distribution at minus 94 degrees Fahrenheit. That's going to be difficult in a lot of rural areas. It's probably going to be difficult to get the vaccine into assisted care facilities at that temperature, and a number of other that'll create some logistical challenges. We kind of recall the challenges that we faced with ramping up testing. Ramping up vaccination is probably going to be a little bit more difficult, and then tying into that, and that's not really that's just my impression. Perhaps Jeff could expand on that, or if he has any difference of a view on that. But what I do know is that these cases are ramping up very rapidly, and the average time from diagnosis to death among people who contract a serious case of it is about 3 weeks. So, and they've already contracted it. Many of these people have already contracted it, so it's too late to vaccinate them. It's going to be too late to vaccinate people who are going to contract it within the next probably 2 to 4 months. The ramp up on this is likely to take many months. So there's a very difficult period coming up as the winter sets in. There's a strong possibility, based on what we've seen in the past, that the rapid rise in cases in the upper Midwest is going to move south as the winter sets in. In the summer, we saw a rapid increase in the south, and I think that was probably due to people congregating indoors due to air conditioning. Now we're going to have the same problem due to congregating indoors because of the cold.
Yeah.
So those are difficulties. Another thing on the vaccine that I wanted to chime in with is that I just looked at a Harris survey that showed that about that the percentage of Americans who are willing to get a vaccine in their surveys has dropped from about 68% to 57% in the past 2 months. And among Black Americans, it's dropped from 65% to 42%. So there's some kind of messaging problem and confidence issue that needs to be addressed in addition to the problem of providing the resources into those communities.
Maybe just to follow on to what Stephen just said, and based on Jeff on your experience, and Jerica, feel free to add in. What's your experience in general in vaccines and adherence on vaccines? People being willing to take vaccines, is that in line with kind of what the general public is on adherence with vaccines?
I think if you use influenza as a model, less than half the population who needs to get a flu shot, which is everyone 6 months and above, gets a flu shot. And this is something we know what the effectiveness is of the vaccine. We know what it does to prevent severe illness and death, but yet still half the population get it. And we know a lot about the safety because it's been around for decades, but yet half the population gets it. So we know that we're going to have a difficult time to get a vaccine, but I think it might be unfortunate, it is unfortunate, that the cases are rising. But if you're in a public health planning situation, when people perceive a crisis and they see a vaccine coming, I'd love to see what that Harris poll looks like after the Moderna announcement and the Pfizer announcement, where now you have a vaccine that's not 50% effective, because that's what the FDA said it as low as 30% that they would approve, but they were targeting 50%. 90% was not what people expected. Does that change what people will think about getting the vaccine? And of course, if we can remove the White House from the whole conversation about vaccines, I think that might also change a bit.
Right. Good. Hey, we're coming up on noon here and we have a few minutes left, but I always want to give everyone a last chance for some final words. So I guess what I want you to address is, as you've all noted, we're at a critical time right now. Cases going up. We're also at a critical time with vaccines on the horizon. Jeff nicely laid it out. Jerica nicely laid out the potential use of therapeutics, and Jason laid out some of the issues around in our communities and the disparities around in our community. I guess what I would like you to respond to is, as we look out, and we all hope that when we get, Jeff laid out the timeline, that hopefully by spring or summer, large portion of our population has vaccines, but that's a ways out. What are your recommendations to kind of get us to that point where next summer, hopefully people are taking vacations, hopefully there's some sense of normalcy? What should people be thinking about? Because this takes a lot of patience. There's a certain amount of fatigue setting in with people. They don't want to be locked down, but these are still serious issues also. So just some quick recommendations, 30 seconds to a minute. Stephen, I'll start with you.
Okay, thanks, Tom. I don't know. I just get outside a lot. I have 40 acres up in the Sierra, and I can go around up there and get some recreation and clear my mind without taking much risk. And that just, I'd also point out that we have about 5 times as many cases as we had at peak cases in early April. And we've got about 2.5 times as many cases as we had at peak cases in early August. So it's out there and it remains just about as lethal as it ever was. So, continue with those precautions and even more so than we have in the past.
All right. Jason?
Oh, thank you. Listen, from a disparities perspective, I really appreciate Dr. Gerstad's comments, for example, but another line of my research shows that, Black and brown communities don't have equitable access to nature, to public spaces, to parks and open spaces. So, I think that's it's sort of a double whammy, and it's a challenge. So my recommendation, mask up. Wear a mask. It's probably the best protection we have, barring a vaccine at this point. My second point would be, look, Black and brown communities have been disenfranchised from healthcare for generations. And I think, going back to your initial question, Tom, in terms of public health messaging, we need to begin to reestablish that trust, especially with vaccinations coming. Therefore, I would strongly recommend that healthcare systems partner with community-based organizations that are working in and with Black and brown communities to begin to reestablish some form of trust, because COVID-19 is a classic example of how Black and brown communities have been sort of underserved. And we need to get back to serving our communities equitably. Thank you.
Jerica, you're next.
Yes, hi. It's definitely a $1 million, $1 billion question, and I want to echo Dr. Douglas's point in terms of masking up. I empathize the communities, because I'm actually part of that community where we live in really dense populations and we don't have the luxury of nature unless we drive about 30-40 minutes away. And I would echo that sentiment. Is it's very important to mask up and to practice the safety precautions that we have been hearing from public officials and scientists. I think the most important thing to realize is that what I'm hearing from different groups of people is that it is our freedom to either mask up or to go in without a mask. I want to just remind everyone, freedom does not come without a cost. And I think it's important that there should not be a confusion between freedoms and responsibilities. And I think it is important that we take responsibility to protect ourselves and our loved ones. And if we are really good citizens and good neighbors of one another, then we should practice being responsible, like wearing a seatbelt when we're driving, or washing our hands before we're eating or after using the restroom. So those are responsibilities that we can take to minimize the spread before we have really proven evidence for a good therapeutic drug, and then before the vaccines roll out to know if they're actually effective, even long-term protection against this disease. So same recommendations as what Dr. Douglas has issued.
Great. And Jeff, you get the last word.
Okay, thanks. No, I love what everyone said here, because I think these are messages that should resonate with everyone. But I think to those people who say, let the disease go, we'll hit herd immunity, we will have to kill millions of people to get herd immunity, right? Even Sweden understands, they want the vaccine, right? So the vaccine is on the way. The vaccine will help us in the pandemic, but it will only help us in the pandemic if people have trust in the process, and if people then get the vaccine, so that we can eventually get to a level where, if you look at a lot of other vaccine preventable diseases, we call them vaccine preventable because the vaccine is controlling outbreaks, is controlling the disease. We need to get to that level. And I think these vaccines are going to be a game changer for this pandemic.
Great. Well, I want to thank the panel for a really great discussion. Thank you all for who attended and posted really great questions. This has been recorded and we'll post it on our website. So if you know people that missed it and want to be able to see it, certainly direct them to the website, Ask the Expert website. Thank you, Joey, Taryn, and Amy for working behind the scenes and making sure everything works well. And with that, we will be finished, and stay well and stay safe. Thank you for attending.
Thank you. Bye.
Thanks.